My name is Dr. Mousa Abbadi from Amman, Jordan. I am a pathologist and cytopathologist at the University of Jordan. Uh, this is my email at the bottom of the slide, just in case there is any question or discussions after the meeting. I work at the University of Jordan College of Medicine. This is our hospital in Amman. And I'm proud to let everybody know that the University of Jordan now is ranked in the top 500 universities by QS Rank, and the first university in Jordan to be ranked in the Shanghai ranking system. The hard work of the leadership and the faculty and the staff paid off. And it is my alma mater, okay? I graduated from this school in 1986. The overview of my talk will be simple since I'm talking to most of the attendees are endocrinologists and surgeons and clinicians. It's going to be just a glimpse of the cytology history. And then we'll talk about the thyroid Bethesda system, the procedure itself, the FNA procedure and technique, and the clues and the tricks to avoid unsatisfactory specimens. What's the role of thyroid FNA for patient management? And we will dive into the Bethesda system since the inception in 2010 until the third edition 2023. We'll talk a little bit about the follicular lesions since they are the ones which sometimes create issues. And I will show you some of the algorithms which I made specifically for our people and pathology. The history of cytology dates back many years back. And I remember I had written probably two monograms about thyroid cytology, about cytology in general. But we have reports of cytology in general dates back to the 1800s and 1700s, even more. This is Dr. George Papanikolaou. This is the Karolinska Institute in Sweden, since they were probably the pioneers in the early 1900s. And this is the Sloan Kettering Memorial Hospital after that. But the true era of proper cytology began actually after Dr. Papanikolaou died in 1962. The history actually needs a specific session to explain. In the last 15, 20 years, we started, the experts in cytology started to standardize the way we report our cytology specimens. And the initial standardization was based on the cervical cytology, 1990, followed by multiple organs. The first organ which followed the cervical cytology standard reporting system is the thyroid cytopathology, which the first edition was published in 2010. We have systems for salivary gland, we have system for urine, we have systems for pancreas, we have systems for lymph nodes, etc. So the number is more than 10 standardized system, which will make the language between the cytopathologist and the clinicians uniform and clear. The Bethesda system for reporting thyroid cytology first edition was created in 2010. The editors of the first edition was Dr. Ali and Dr. Sebas. Dr. Ali from Johns Hopkins, Sebas from Harvard Medical School. The second edition was edited in 2017. And the third one was just 2 years ago in 2023. We're going to talk a little bit about the differences between these systems and establish the background of the initial 2010 Bethesda system. The overall impact of fine needle aspiration cytology of thyroid is, as we know, it is the best initial test for evaluating thyroid nodules. It's very accurate, simple, and safe and cost effective. And those are, and the sensitivity and the specificity and the accuracy is quite good and important. It actually decreased the number of patients requiring thyroid surgery, and this is probably one of the main objectives of preoperative evaluation of thyroid nodules. We have to pick which patients need surgery, which patient does not need surgery. And consequently, it decreased the cost of managing thyroid lesions by at least 25%, and probably the number is much higher nowadays. It also increased the yield of finding thyroid malignancy at the time of surgery by at least 3 times more than before establishing the diagnosis. So the value of thyroid fine needle aspiration, number one, we have to remember that for follicular lesions or oncocytic lesions, used to be called here, test, it is difficult and almost impossible to diagnose follicular lesions specifically, differentiating adenomas from carcinomas based on cytology, because as we all know, the criteria for establishing the diagnosis of malignancy in follicular lesions is establishing the presence of vascular invasion and capsular invasion, which cannot be done on cytology. However, it is a diagnostic test for the rest of the lesions, for papillary thyroid carcinoma, for chronic thyroiditis, for anaplastic carcinoma, for medullary carcinoma, and lymphomas. So, and since the most common malignancy of thyroid carcinoma is papillary thyroid carcinoma, this gives fine needle aspiration of the thyroid a much bigger value. The technique itself, it is variable. A lot of people demonstrate different ways. The issue here for us is to receive a satisfactory sample. The consensus on the agreement of what establishes a criteria for adequacy is the presence of multiple groups, 5 to 7 groups of well-preserved follicular cells, where each group is at least 10 to 25 slides, 25 cells on 2 different slides. And many people say 2 passes is adequate. Some people say 3 passes is needed. I remember one of the initial people established the technique, recommended even 5 passes or 5 insertions of the needle in the lesion. However, this is probably the general consensus on how we cytopathologists evaluate that the sample is adequate. The rule of thumb, it is operator dependent, and currently everybody agrees that ultrasound guided approach is the standard of care, especially on smaller lesions. This is one of the clues or technical tricks that you can utilize, especially when you're dealing with a cystic lesion. The thyroid gland is notorious to have cystic degeneration, cystic carcinomas. So to be able to evaluate the inner side of the cystic lesions, you have to, when you insert your needle and you discover that you are dealing with a cyst fluid, you can keep the needle, the tip of the needle inside the lesion, do not withdraw the needle, evacuate the whole cystic components for cytological evaluation, and then re-aspirate while the tip of the needle is inside, so that you can sample the cyst wall from inside and decrease the number of inadequate samples and decrease the chance of false negative, especially in cystic carcinomas. The accuracy, sensitivity, and specificity is quite excellent. It is one of the best among different organs. Those numbers are available everywhere, and with proper techniques and proper adequacy, those numbers actually can be even higher. Let me just switch now to simple basic cytological interpretation from our side. The science and the art of cytopathology is very simple. Most of the lesions are benign, or we call them the good and the bad and the ugly. The good lesions are straightforward and easy to interpret. The ugly ones, when you have an ugly carcinoma, it's very simple to make a diagnosis even with one pass. The problem comes with atypical lesions or the lesions which are in the middle, and those are the ones which create a big problem in the evaluation of cytology in general. But basically, most of the lesions are either categorized as benign, or if it is obviously malignant, it's easy to interpret. I am an American trained cytopathologist, but I'm aware of the United Kingdom thyroid system, which is called the Thai system. And I'm just created this table to compare and contrast between the Bethesda system for reporting thyroid cytology, especially the 2023, and the what parallels those diagnostic categories. We have 6 diagnostic categories. The non-diagnostic category is parallel to Thy1 or Thy1C when there is a cyst in the thyroid in the British system. The benign, which is Bethesda 2, is parallel with thyroid or Thy2 non-neoplastic, or Thy2 cyst, which is non-neoplastic cystic, and so on and so forth. The Bethesda 3 atypical cells of undetermined significance is comparable with Thy3A, which is a neoplasm with possible atypia. And the other ones are actually similar. So this is a table which helps compare for people who are used to the British Thai system. This is the original table which was created in the 2010 edition of the Bethesda reporting system, and we will show you the major differences between the categories which are seen in 2010 compared to 2003. There are 6 categories, and we will focus on the changes. But I need to remind you all that the initial Bethesda system of 2010 was based on 2 excellent papers, one from the Galveston University of Texas program, around 5,000 patients, and then the Harvard group, about 2,500 patients with appropriate follow-up. So those are the 2 basic papers that created the 2010 Bethesda system, documenting the presence of 6 categories: the unsatisfactory or non-diagnostic, the benign, the atypical group, the follicular group, the suspicious group, and the malignant group. The problem with the follicular lesions is this is a very nice diagram which I borrowed from Dr. Richard DeMay book, in which the more colloid you have and the less cells you have, you are in zone 1, which you are getting into the benign category. The more cells you have and the less colloid you have, you are in zone 3, which makes you worry about follicular lesions. And we have to narrow down this line and this line to make sure that we are establishing a difference between a neoplastic follicular lesion or a hyperplastic or benign nodule. However, we need probably ancillary studies to differentiate these 2. Going back to the Bethesda system for thyroid cytology in 2010, the highlighted areas are the one which has the major difference. If you remember, category 1 was non-diagnostic or unsatisfactory. Now they're using non-diagnostic. Personally, I like unsatisfactory so that the clinicians understand clearly that I cannot rule in or rule out any thing. But the consensus now is to remove the word unsatisfactory and just call it non-diagnostic. The benign category stayed the same. The category 3, ATP of undetermined significance or follicular lesion of undetermined significance, they removed this part, so it is ATP of undetermined significance. And the category 4 was changed, and this is the current 2023 categories. Category 1 is non-diagnostic. The benign stayed the same. Category 3 is atypia of undetermined significance. You can actually specify the degree of atypia. And number 4 was switched to follicular neoplasm, and you can specify then if it's encocytic or regular follicular lesion. The suspicious and the malignant stayed the same. In addition to that, the 2023 category included the NIFT-P, the NIFT-P category, if you consider the NIFT-P a cancer and if you consider the NIFT-P non-cancer, and gives you the risk of malignancy for both adults and also pediatric patients with a usual recommendation for management, whether it's repeat or lobectomy or try to establish molecular testing if available. This is the molecular pathways of most of the thyroid carcinoma. This is a paper which we published just last year. If you are interested, there are a lot of good details for your sake if you are interested to see these diagrams and pathways. The addition, the other thing which has been added in the 2023 is establishing also a specific table for pediatric patients where the management is a little bit more aggressive and the risk of malignancy is a little bit different. So this is the table which was added in the 2023 edition of the Bethesda system. Finally, if you, from a cytopathology point of view, looking at the algorithms and diagrams, when we have a thyroid FNA, the first thing we have to do is assess adequacy. If it is non-diagnostic or unsatisfactory versus satisfactory, utilizing the criteria which I mentioned. If the specimen is satisfactory on the slide, we look at the major components. Are they epithelial, inflammatory, colloid, or cystic lesions? After establishing which box we are in, we continue to the next diagram. If it is epithelial, we immediately go to see if there is any papillary thyroid carcinoma features, and the most important features in PTC is the nuclear features. If it is there, it is papillary thyroid carcinoma. Between category 5 and category 6, myself personally, I like to see pseudo inclusions to call it Bethesda 6. If I have everything except the inclusions, I call it Bethesda 5. And then you go to the rest of the, if there is no papillary thyroid carcinoma, you switch to other malignancies, anaplastic, lymphoma, medullary thyroid carcinoma, or metastasis. If the background is mainly inflammatory and if it's predominantly lymphocytes, if they are monotonous, you go to probably suspicious for lymphoma, and you have to do clonal studies by flow cytometry or immunohistochemistry. Otherwise, most of the cases are under the category of chronic thyroiditis. If there is Hürthle cells, it is consistent with Hashimoto's thyroiditis. If the Hürthle cells are not present, we are talking about non-specific thyroiditis. I need to draw your attention is if we see too many neutrophils in the background of any finite respiration of thyroid nodules, especially in older patients above the age of 70, we have to make sure that we are ruling out anaplastic thyroid carcinoma, because the presence of neutrophils is quite characteristic of a background of anaplastic thyroid carcinoma. Granulomatous thyroiditis, subacute thyroiditis, you will see multinucleated giant cells. And If you are dealing with a stony, hard nodule of the thyroid and you rarely have or aspirate epithelial cells, probably you are dealing with a Riedel's thyroiditis. If the predominant material on the slide is colloid, we are talking about colloid nodules. We require to see, as we said, epithelial groups to make sure that we have adequate sampling. And you always look for papillary thyroid carcinoma features, especially nuclear features. Cystic lesions, again, you look at the groups and the cells and the nuclei. If you have PTC nuclei, it is cystic papillary thyroid carcinoma. If the papillary features are absent, we are talking about adenomatous nodule or non-follicular cyst or cystic follicular neoplasm, where you need probably better sampling. The last couple of slides emphasizes the teams that are involved in decision making. The patient himself also is an important player, internist, endocrinologist, or primary care providers, radiologists who give you information about the imaging features, the pathologist, the surgeon, and the radiotherapist. In summary, thyroid fine needle aspiration is partly screening tool, therefore conclusive diagnosis is not always can be made. Our role as a pathologist is to minimize the number of undetermined diagnoses without yielding an unacceptable false negative and false positive rates. The FNA can assign diagnostic probabilities that can help guide management in many cases, hence the establishment of the thyroid Bethesda system for reporting thyroid cytology. It is now a well established as a pre-op evaluation of thyroid nodules, and as hence we have like 3 editions of the Bethesda system. I need to emphasize the close cooperation between the clinicians and the pathologist and the radiologist to have clear understanding, especially when we speak, when we create reports and to understand the language used in our report. The last thing which I would probably ask everybody to pitch in is some people and some centers, even in the United States, they will include in their report the table that is found in the Bethesda system. So this table sometimes will put as at the end of each cytology report. Myself, I don't do that, but probably some people can use it and can defend their decision. Thank you so much. This is my email. I'll be glad to receive any comments, questions, inquiries in my email. And thank you so much. عيد مبارك كل عام وأنتم بخير.